Okay, we thought we would start first with some introductions. Many of us do know each other. However, it's good to just kind of open with an introduction. We'd also like to ask if you would just give us a few sentences on sort of why you're here and what you'd like to accomplish with this effort. And we'd love to just give you an opportunity to present your thoughts as we kick off. I'd like to start first by introducing myself. I'm Jennifer Strohecker. I am the Medicaid Director and the Director of the Division of Integrated Healthcare. I would like to introduce the team that is in the Director's office with us and serves within the Division of Integrated Healthcare, and give these individuals a chance to introduce themselves as well. Brent, would you like to begin?
Thank you. I apologize. My camera is working this morning, but my name is Brent Kelsey. I think I know most of you. I'm the Assistant Division Director within the Division of Integrated Health for Behavioral Health, and the Office Director for the Office of Substance Use and Mental Health. And I look forward to these discussions, and I think we've got a great group to help us identify the future of TAM. So thanks, Jen, and look forward to working with all of you.
Thanks, Brent. Brian and Eric.
Hello, Brian Roach. I'm another Assistant Director with the Division of Integrated Healthcare. Likewise, I know many of you, and look forward to providing support to this work group. Thanks.
Hi, I'm Eric Grant. I'm the final Assistant Division Director for the Division of Integrated Healthcare. Glad to be here and happy to lend whatever assistance I can to this endeavor.
Thank you, Eric. And then Nate.
Yeah, Nate Checketts, Executive Director, Department of Health, and in Health and Human Services, I'll be the Deputy Director over Healthcare Administration, which includes both the Medicaid program and also the substance use and mental health services. As this group gets together, just really excited about the opportunity to look at new and building on the ways we've been looking at integration. I think we have a great start with our integrated plans, and want to be able to talk about that model and other models with this group about the best way to try to bring better physical and behavioral health.
Thank you, Nate. So let's move to introductions for the behavioral health work group that we've assembled. I do have a list I want to make sure most of you are on, but I'll just work from the top of my list down. Julie?
Yeah, I'm Julie Ewing, and I'm the Director of Compliance for the University of Utah Health Plans. And we're just excited to be here and, participate in this exciting project to help the folks who are on the TAM program.
Thank you, Julie. Russ?
Good morning, Russ Elbell with Select Health. Also very excited on the discussion of further integrating care and coverage and service for the TAM population.
Thank you, Russ. Jennifer?
Good morning. My name is Jennifer Ford. I'm the Director of Clinical Operations for Health Choice Utah, and I'm looking forward to learning more about this delicate population and what we can do to best support them as we onboard them to the plans.
Thank you, Jennifer. Brandon? Oh, I guess Brian.
Hi, I'm Brian Monson, the Vice President of Government Programs for Molina, and Molina is a national Medicaid plan that has been around for about 35 years, and we are excited about this opportunity because we feel like we've seen programs similar to this, and we feel like we have some national solutions that can help these individuals out and help the state.
Thank you, Brian. Is Nina on the line? Okay, Adam?
Oh, did you say Nina?
Oh, sorry, Nina. Yes, Nina, hi.
Hey, so Nina Farrell, Salt Lake Behavioral Health Hospital. I'm the Assistant Director of Business Development, and I have about 30 years experience working with folks with pretty severe mental illnesses and brain injuries and so on. So I'm just excited to have a place at this table to talk about solutions, especially for integrating acute care, because I think we need to do a much better job of making sure we get stronger outcomes. And working with our community partners at all levels. So I'm excited to learn from all of you folks. So thank you.
Thank you, Nina. Adam?
Good morning. I'm Adam Cohen. I'm the CEO of Odyssey House. I'm excited to participate in this group and excited to work out solutions to make the delivery of services for this very special population as good as possible. So thank you.
Thank you, Adam. Lisa? Okay, Jed?
Hey, my name's Jed Burton. I am the clinical director here at Weber Human Services, and really here to help represent community behavioral health centers, and really just hope to work out some coordination with all of our partners.
Thank you, Jed. Jake?
Good morning, Jake Schoaf. I'm the CEO of the Phoenix Recovery Center. I'm also the president of the Utah Association of Behavioral Health Organizations. So I'm excited to be here and collaborate with this body about the integration of TAM. So I'm excited to go through this over upcoming months.
Thank you, Jake. Patrick? Okay, Tim?
Hi, Tim Whalen. I'm the Director of Salt Lake County Behavioral Health. I've been in this position for about 10 years now, and I'm really looking forward to the discussion to, improve the overall outcomes for care in our county, and just happy to participate. Thank you.
Thank you, Tim.
Hey, Jen,
Elizabeth? Oh, I'm sorry. Hi, Patrick. Go ahead.
Pat Fleming. I'm sorry, I was muted. Yeah, Pat Fleming, Chair of USAVE. Glad to be on the committee. Concerned about integrating TAM, which everybody knows is one of the most fragile populations we have. So I want to make sure we really do a good job on this. It's so important. Medicaid is such an important resource for this population. So thanks.
Thank you so much, Patrick. Senator Kennedy? Okay, Representative Dunnigan.
Good morning. I'm excited to join with you. So I'm Jim Dunnigan, representative from Salt Lake County. I had the opportunity to author the TAM language and sponsor it, and looking forward to our discussion, and think that what we learn and do here may very well spill over into other populations of Medicaid and inform the other populations as well. So thank you.
Thank you, Representative. Audrey.
Jen, hi. Audrey asked if I might introduce both of us, but I'm Matt Hansen, the Executive Director for the Home Care and Hospice Association of Utah. And Audrey Wood is on with us as well, who works with our association, but we're here by invitation from Representative Dunnigan. Just as he mentioned, to kind of listen more than anything, and because of the implications that this conversation could have on other populations in behavioral health. So thank you for the invitation.
You're welcome. Thank you, Matt and Audrey, for being present. Eliana.
Good morning. Thank you, Jennifer. Government Relations for Select Health. And I'm really looking forward to hearing from our behavioral health providers and building a trusting relationship with open communication so we can deal with this very fragile population together.
Thank you, Eliana. Katie? We may have lost her here. We'll come back to Katie. Kyle.
Hi, I'm Kyle Snow from Northeastern Counseling out in the Una Basin. Represent the rural component, I hope, and then also the behavioral health centers throughout the state. I'm the vice chair of the Utah Behavioral Health Care Network.
Thanks for joining us, Kyle. Katie, we'll go back to you. Okay. Joel?
Jill, I think you're muted.
Right on. Can you hear me now?
Yes.
Can you hear Barry White's cousin? No, I'm just kidding. Joel Johnson with the Association of Behavioral Healthcare Organizations, and then I also represent the counties as well as local authorities and other actors kind of across the board. And TAM has been a labor of love for me for since kind of my inception into politics, and so I'm looking forward to what we can do here to make sure we maintain the integrity of TAM and the any possibility that we can offer to access the treatment. So that's all.
Thank you, Joel. Is there anyone else on the work group that I may have missed that would like to introduce themselves?
Hey, I'm going to try again. Thank you. It's Katie Carlson. I'm sorry, I'm on my phone. I'm not used to doing these meetings on my phone, but I have to drive somewhere in a minute. So anyway, I am very happy to be here. I'm a psychiatrist and addiction medicine specialist. I'm the medical director at Project Reality, hoping to learn what I can. We all share common goals and hoping to bring a medical perspective when that's needed. So thanks, everyone. And apologies again for the technical problems.
Thank you. We're really glad to have you join us. And Travis. Oh, I think you're muted, Travis. On the bottom, if you're on your phone, you have to click on *6, or the speaker is on the bottom left of the action bar. Todd, let's jump to you quickly and come back to Travis.
Yeah, no problem. Thank you. Todd Wood, also with Select Health, and really can just echo the sentiments already shared. Excitement to try to figure out how we can best integrate this population, integrate services for this population to serve them in the best way possible. Thank you.
Thanks, Todd. Okay, Travis.
Hi, sorry about that. I'm not all that technologically advanced. Travis Wood, I also represent the Utah Association of Counties and Utah Association of Behavioral Health Organizations, amongst a host of other people within the network. And I too look forward to this collaboration. I hope we can get some good work done. Thank you.
Thank you, Travis. Okay, well, we'll just close our introductions with a truly heartfelt thank you to all of you for gathering and contributing your time to this important work. It's just our first of many meetings to look at the management of this important population and work together to achieve a common goal for this group. So we really appreciate the contributions of your perspectives, your expertise, your knowledge of this group of individuals, and all that you have to share in this effort. So thank you so much for your time today, and also moving forward into our future meetings. We're going to transition first to really spend the next 30 minutes or so looking at the patient population that we intend to serve through our work here. And as we prepared for this meeting, it was very important for us to stay person-centered in our approach. There are unique needs that this population has. Many of us, most of us have been, or all of us have been working with this group for some time now, and we understand the complicated nature that this group does present. And with that, we really want to start by talking about the history of this group, and Nate will cover that piece. And then we're going to move into some utilization data that looks at an evaluation of use trends from our Medicaid claims data, and Brian will be presenting that. So this information on the data was shared with you in an email. So if you didn't get a chance to see that email, I sent it out yesterday morning, and it included the slides that we'll cover around the data. But for right now, I'd like to just transition over to Nate to give a background of the TAM population and kind of the story that we've had with this group over the years.
Yeah, thanks, Jen. And I know for many of you, what we'll talk about in the next few minutes is lived experience, and some of you were the primary actors in this experience. So, So I hope you'll feel free to add or correct as I go through and run through some of these things. But for some of those that have less experience with what Utah's been doing with this population over the years, we thought it would be helpful to cover this ground. Historically, the adult population is an area that Medicaid has not had significant coverage in across the country, and in particular in Utah over the years. Utah was innovative many years ago to establish the primary care network program to try to provide some amount of coverage to these individuals. But as many of you know, that program had an extremely limited benefit package. And although it did provide those helpful services that were covered, it left many things like inpatient hospital and other important treatments off of that coverage package. In 2016, Representative Dunnigan and Senator Christensen ran a bill to establish the targeted adult population, although it wasn't called that at the time. We were still developing that name and how we were going to treat that group. But that set in motion this process of bringing a full coverage package to this group. In 2017, we were actually able to start those coverage populations as different waivers were approved. We started first with the parent population, and we're able to expand coverage to them at a higher income level than we had before. And then in November, we were able to tag team two different approvals that were critical to the establishment of this group. Not only did we start the targeted adult population, which allowed us to cover adults without dependent children at super low income levels if they met certain criteria, such as coming out of prisons and other targeted populations. But possibly as important, we also received approval from the federal government to begin covering substance use residential treatment. And so that combination has really allowed us as a state to take a significant role in this population. And then as we moved into 2018 and 2019, and the state began considering full Medicaid expansion, we were able to get approval to sort of tuck the approvals and the program of targeted adult Medicaid within the larger expansion work. And so while we are a Medicaid expansion state, we continue to operate the targeted adult Medicaid population with some special rules and benefits for that specific group. And so that has allowed us to continue to provide 12-month continuous eligibility and other services to this group that maybe haven't been available to the broader population. So with that short history, I don't know if any others want to add to that, but we just wanted to run through that. I guess one other point that I wanted to make, one of the other things that has been unique in the development of this program, whereas funding for behavioral health for the rest of the Medicaid population has gone through, in part through substance use and mental health, and in part come from match from the counties. The funding for the behavioral health for these populations, for these expansion populations, have come through the Medicaid program. And so that has allowed for a different direction and a different focus and some opportunities for us to do some of these integrated funding programs since that funding was all in one place, both the physical and behavioral health. So with that, I don't know if anyone in the group wants to sort of add or build on that short summary. Okay, I'll turn it back over to you, Jen.
Okay, thank you, Nate. All right, as I said, we're now going to present some utilization data on this population, and Brian will walk through this data with us. There's more data that we have. We decided to start with an overview today, but certainly we want to reorient back to this as we proceed in our discussions around the population, and certainly there's more to share, but today is an overview. So go ahead, Brian, if you would begin to present the slides.
Yes, certainly. One moment. And I think we do have one attendee by phone, so you won't be able to see me scroll through the presentation, but as Jennifer mentioned, she did email that out yesterday morning, so yeah, feel free to review it, and that goes for the rest of the work group as well. I won't read word for word on this or talk about every data point. This is available for your review outside of this meeting, but I will go through the entire report. So starting off with a review of the enrollment over the years, as Nate mentioned, this did begin in November 2017. Highlight of the program is it does offer 12-month continuous eligibility, so individuals are guaranteed 12 months, and so you do see a consistent upward trend in the first 12 months as individuals were not disenrolling from the program. About 12 months afterwards, we do start seeing what we call a churn in cases, so individuals leaving the program and new ones coming on. And enrollment stayed between 4,000 and 5,000 for about a year and a half. And then the next major event that happened was the pandemic. And with the pandemic and the public health emergency, all Medicaid programs have been forced to keep cases open as what's called a maintenance of effort. So cases are only allowed to close in cases of member death, moving out of state, or requested closure by the member. So that has grown the program substantially to what it is today, about over 9,100 cases on the program. We're still in a public health emergency. We expect probably the current end date of July to be extended. But that will continue to grow until the public health emergency ends, and then we will probably experience a ramp down in enrollment. But where it ends up is hard to predict. Next, scrolling down on page 2 are the Tam subgroups and demographics. So there are 3 main subgroups of TAM: the justice-involved individuals, those experiencing chronic homelessness, and the general assistance program, which is quite a bit smaller. So the large majority are in that justice-involved category, about 3/4 of them. And then next highest is those experiencing chronic homelessness. As far as age groups, you can see, first of all, a very large concentration in males. This is predominantly males, about 79%. As far as ages are concerned, largely in the 30 to 39-year-olds. If you go up to 44-year-olds, that does represent a majority of the entire TAM population between 30 and 44. So there still are individuals represented all the way up to 64 and down to age 19, but largely concentrated in that 30 to 44 age range. Scrolling down some more, the primary language, this is heavily concentrated in English speaking. There's a 0.5% Spanish speaking and a small amount of other language speakers, but the English speaking is very highly concentrated in this population. As far as race and ethnicity, the first caveat is that a large amount of members in this population and the broader Medicaid population choose to not disclose their race to us, which is their right. But so we do have some limited race ethnicity outside of that large other or missing group, but predominantly white, about 39% of the overall population, followed by Hispanic other race, and then American Indian, Alaska Native, and Black members make up about 3%. Scrolling down, we're now on page 3, reflecting the location of TAM members. This is heavily concentrated in urban areas. So Salt Lake County alone does have the majority of TAM members at 56%, followed by Weber Morgan, concentrated in the Ogden area at 13%, and then Utah County at 10%. There are a few or a couple Southwest and Davis at 5%, Southwest that is concentrated in the Washington County region, and some Iron County. And then there are about, I believe it's about 17% live outside of the Wasatch Front. So largely urban, largely Wasatch Front. Scrolling down some more, we're now on page 4. Service delivery for TAM members. As some of you may imagine, there's several different ways to display this data, and more detail we could go into potentially over further work group meetings. But just a perspective of access that TAM members have had over the last year. So I focused on the year 2021. We can all acknowledge that there's some effect of the pandemic in access to services, but I used 2021 for some recency. So about 62% of members accessed pharmacy dispensed medication in 2021. I'll have more detail below. 52% had a primary care visit. A quick caveat on that, we don't particularly have a data field that identifies a primary care physician or APRN for a member, but we can tell based on the specialty of the physician. So this is labeled when I see a general practice or family medicine or internal medicine physician or an APRN. I identify that as primary care in this data. About 47% access substance use treatment in outpatient or residential setting. 45% laboratory or diagnostic service. A large amount of that is urine drug testing. About 39% access the emergency room, 14% mental health treatment, and then 13% receive dental service. The TAM members have a special provision for dental services that extended the benefit only for individuals that are actively engaged in a substance use treatment program that is offered through the University of Utah School of Dentistry. Other TAM members are able to access emergency dental services, so that does exist, but not everyone has access to the routine service. It's only individuals actively engaged in substance use treatment. And then about 10% received an inpatient hospitalization in 2021. As far as medications, I did compare this to the non-TAM population, and the distribution is fairly similar. So these aren't too dissimilar from the broader Medicaid population. But the largest drug group dispensed is antidepressants. 31% of TAM members did receive an antidepressant in 2021, followed by anticonvulsants like gabapentin, analgesics like NSAIDs, antipsychotics. The next, this is now fifth in the list, is medication-assisted treatment like Suboxone and Vivitrol. And then the rest of the list is there. I would welcome, obviously, our director, Jen, has a pharmacy background, and she may be able to comment on this if any of the work group has specific questions. Scrolling down some more to the provider network. Again, there's several ways I could have shown this. This is just probably a 50,000 foot level, and the 5 most commonly serving providers that I saw in 2021. The hospital-based services, these are pretty exclusively in Salt Lake County, reflecting the concentration of members in Salt Lake County. So those are the 5 hospitals that served the most TAM clients in 2021. For behavioral health, Odyssey House is at the top of the list. Adam, it's good to have you present. Valley Behavioral Health next, Volunteers of America, First Step House, and Wasatch Behavioral Health round out that list. On the third column, this is just a mixture of other and some integrated clinics that we saw serving our clients. So the Martindale Clinic, 4th Street Clinic, the University Hospital School of Dentistry, as I mentioned, does provide dental services with that special program. The Sacred Circle Clinic, and then the Mountain Lands Community Health Center. Scrolling down and looking at chronic conditions received, looking at diagnoses to identify the chronic conditions identified within our TAM member group. There is a heavy concentration of substance use disorder seen. Roughly 2/3 of members in TAM have a substance use disorder. 6,300 out of about 9,300 members. So that is at the top of the list. Next is depression, bipolar, and other depressive mood disorders, followed by hypertension, rheumatoid arthritis, and asthma, and then the rest of the list is there. We're at the top of page 6. So this is still just a subset of chronic health conditions. The full chronic condition data warehouse has 30 conditions, and then I've added substance use disorder on top of that. So I've just displayed the top 10 for this group, and we can provide more data upon request. Looking at number of concurrent chronic conditions, about 2,700 members only have one chronic condition. And then if you add up all of these that have 2 or more, that's about 4,600 TAM members that have more than one. About 2,200 of them have 2, and then you can see the rest of the group. So this is the number of concurrent chronic conditions and the number of TAM members that experience that. Specifically looking at the co-occurring behavioral and physical health conditions. So behavioral would be both substance use disorder and the depression, bipolar, or other depressive mood disorder chronic conditions. About 3,000 TAM members have a behavioral health condition and a co-occurring physical health chronic condition. The most common of which is hypertension, reflecting about 1,300 members, followed by rheumatoid arthritis, osteoarthritis, and asthma. We have noticed that is a little bit interesting of an observation, given that our population is concentrated in those 30 to 45 age range groups. I mean, there are individuals at a higher age range, but the fact that rheumatoid arthritis is one of the most common co-occurring conditions with behavioral health is interesting. And finally, scrolling down to cost information, we do commonly use the term per member per month, or PMPM, to reflect cost of members, especially in rate setting. We commonly group individuals into the three main categories of physical health, behavioral health, and dental. There is a lot more detail behind these numbers, but TAM members cost in total about $1,200 per member per month. And when you look at the reimbursement by decile, so taking the top 10% of TAM members, then next 10%, et cetera, you see the distribution of their costs. So about 53% of overall TAM costs are experienced by the top decile of TAM members. And then about 21% of TAM costs in the next decile. So that top 20% of TAM members accounts for about 74% of all expenditures. And then you can see how this, it looks a little bit like a funnel diagram, goes down from there. So with that, I will be happy to take any questions. And Jen, if you want to make any comments as well.
Brian, I'm going to jump in with a question. It's Kitty Carlson. Do you have further breakdown of the costs, like on the physical health side? Is that what portion is hospital, ED, outpatient visit, pharmacy, et cetera, and same on behavioral health side?
Not with me. Would it be helpful though to see it in like a per member per month fashion or overall expenditures? What would be helpful?
I probably don't know data well enough to know for sure. I guess I lean toward kind of maybe aggregate annual costs, but I'm really not certain. Sure. I just think it's important if to look at where the high costs are. I'm sure that's part of our goal here, to see where we can distribute the costs in a way that gets better outcomes.
Sounds good. Yes, we can provide it. Russ, and then Representative Dunnigan.
Thanks, Brian. Thanks for presenting this. I think aggregate costs will be useful to see, but I do think the per member per month cost across those different breakouts, inpatient, outpatient, and breakdowns of services will be helpful. That will really give an idea. And if it's possible to see trend on those, over time, that is always useful information.
Yeah, I can certainly provide that next time.
All right, thank you.
Mm-hmm. Yeah, Representative. Yeah,
thank you. So this is terrific. Thank you very much. A couple of questions. So I'm interested in similar information on the hospitals. I'd like to see what the ED is. I think it might be interesting to see what the encounters are. I know that doesn't show the dollars, but I'm interested in seeing how many encounters we're having with the ED. And then on the 1205 PM, how does that compare to the expansion overall? Do you know that, or could you get that for us?
Off the top of my head, I do believe there is a large difference between the childless adults and the parents in expansion. So childless adults are right about 1,000 PMPM, if I recall correctly, and then parents are around 500 or so. Eric, if you know better, please correct me, but I can get some specific comparison points for you on that next time, or between meetings.
Okay, so when you say parents, or not parents, childless adults, would that include TAM, as a subset of that? Is total
No, I'm just talking about, the non-TAM expansion, childless adults. Yeah.
Okay, so TAM's maybe 20% higher, roughly, but it's somewhat close to the other childless adults, right? 1,000 versus 1,200 versus the parents are half. So that's really something. And I'm interested if anybody wants to opine why there's so much arthritis on relatively young people. I'm curious. We've got a lot of brain power here. So when you figure that out, I'd like to know the answer. Thank you.
Yeah, thank you.
I think I got to add something too.
Please.
I think we should be asking, even though hypertension is a common chronic condition, when we look at the age group there, we should be asking, what's accounting for that. So I think those would be great questions to kind of take a little deeper dive into.
Brian, if I can just sneak back in real quick, I'm interested in the providers or the clinicians. Does this population, because of their life they live and a lot of homelessness, does that effectively age their body, more rapidly than others? Or I'm just wondering. Thanks.
I'm sorry, I'm dominating the airspace here, but I'm gonna. This really touches on kind of my interest in trying to learn from this group, but I'm an addiction psychiatrist, so I look through that lens. So I should just, warn everyone of that. But when I look at this data, it matches kind of with what I think about this population. This is reflective. TAM population is not the only population our clinic serves, but it reflects the struggles and the conditions that our greater population has. And substance use disorders, and then kind of the psychosocial poverty lifestyle accounts for a lot of the hypertension that we see in our clinic. Rheumatoid arthritis, that goes above my pay grade. I'm a psychiatrist. I'm going to be tapping into colleagues to try to look at that. It's a pain diagnosis. So, it leads to a lot of problematic and not always real effective treatments. And if it's truly rheumatoid arthritis, very expensive treatments that not everyone can tolerate. And it takes a lot of stability in order to receive that type of treatment. So, but I think if we kind of take a step back and not look at the zebras, we're looking at this population, that high rates of substance use disorder, a lot of kind of deferred or neglected primary health care for, the first 2 decades of life. So I think that's important to just consider.
Yeah, just quickly, if I could just touch on Dr. Carlson, what you're saying. What I find interesting as we're talking about the conditions, let's look at the utilization of medicines as we're just spending a few moments here. And I agree, it's an unusual kind of profile for this age group. And I was myself wondering if it's just a lack of establishment with primary care in a really meaningful way, and we'll let others comment. But if you want to look here just at the use of NSAIDs as our top 3, I think, which would correlate with that rheumatoid and you sort of that, arthritis indication, and then antihypertensive. Clonidine, we know it's not necessarily used as a first-line antihypertensive by any means, but can be used for the management of some of the other substance use conditions. ACE inhibitors, we see that. But if we look at the medicine profile, I think we have more to look at here, because the behavioral health conditions aren't always showing up as some of our top chronic conditions, yet they're among the top prescribed drugs. So what part of the reason we shared some of this data with you is so you could look at it and think about it, because we have more evaluation of this to do. And certainly this is a high level look. We can dive deeper into many of these areas for you in future meetings. So I appreciate the questions, and I'll stop talking now, but did want to just go back to the medicines that were showing up to see how they matched up with the conditions that we're seeing tied to some of the claims. Nina, sorry. And Brian, I'll pass back to you. So go ahead, Nina.
Yeah, and I apologize. My internet keeps dropping this call, so if I go away, that's why. My question was, is it possible to get data on the types of behavioral health care these folks have had before they needed a higher level of care? I think it might be interesting to help us kind of guide where we need to intervene and put services before they hit the acute stage. And I'm wondering if there's any way of knowing if someone goes into an acute hospital, had they received general outpatient, had they seen a primary care provider, had they been in a PHP or IOP before they admitted or not. Is there any way to get data like that?
A little bit. Yeah, I mean, we can try to infer based on service dates and seeing. I won't always be able to tell the reason of leaving an outpatient or residential. Are you considering outpatient and residential before moving to an acute care setting as well? So yeah, potentially.
Just wondering, I think if we could maybe analyze a little bit of the data of which programs are most effective at what stage, and really look at it kind of holistically. I think it could be really an interesting integration of behavioral health with medical, if we could kind of track some folks. And because what is concerning to me is folks are suddenly acute and they're put in an inpatient unit, right? And sometimes it's absolutely necessary, but I think as a whole, if we could start looking at some of the building blocks to prevent that very early on, that it might help. And it'd be very interesting to see the data about when folks are needing inpatient, and are these programs specifically help, which ones are helping, which ones are not, to prevent these really costly inpatient admissions, I guess is what I'm looking for.
And I think that could very well be valuable. Yeah, it does make sense. I think my only worry is that it may there may be some confounding factors of like selection bias of which clinics treat which clients. So some may look more or less successful if we do compare one to another. But let me pull some data on that and see what I can find.
Thank you.
Yeah, thank you. Janita.
Hi, yeah, thank you for the opportunity to listen in and speak. So I would say this patient profile looks pretty much exactly what I would have anticipated it to look like. It looks very similar to what we look at when we look at our data at 4th Street in terms of our top diagnostics and what we're prescribing. And so we've had, for example, a rheumatoid arthritis specialist who's volunteered at the clinic for over 10 years, because we do see a lot of arthritic conditions in our patients due to the lifestyle, and I think also due to some of them being on antipsychotics for long periods of time, and also due to substance use disorder for long periods of time, and just that lifestyle of living on the street. And so this looks very much like kind of what we see on a day-to-day basis in the homeless population, regardless of the payer that's attached to them. I would be curious on your hypertension diagnosis, or if those are coming through the ED or if those are coming through primary care providers, because I think that speaks a lot to some of the other questions that have come up. And we do see a lot of that people will come in with a hypertension diagnosis through the ED because they're in crisis. And then when they're able to come into primary care, it's not necessarily any longer.
It's a good question, Janita. Yeah, in the data presented, it's either or, but I could try to get a breakdown of where the diagnosis came from. Yep, thanks. Adam?
Yeah, I have a question about the PMPM, and has that changed? Has that changed over time? So the reason why I'm asking is I remember some of the MAC meetings earlier on where the PMPM was much higher. I just wonder if that's related to people not rolling off the program, because typically we've seen the individuals that we're serving come in, we get them eligible or get them on the program, get them treatment, and then they roll off because they get a job and are doing better. So I just wonder if, given that logic that they're doing better, but they haven't rolled off the program, they're maybe not as highly utilizing services, given the pandemic. So I just wonder if, prior to March 1, 2020, is the PMPM, is the $1,200 a month actually accurate once the PHE ends?
It's a good point, Adam. Yeah, it has decreased a little bit during the pandemic. That effect of individuals staying on the program who may not even need the program or utilize, that has decreased the PMPM a little bit. Another confounding factor in those early MAC meetings was a lot of those raw numbers included some raw expenses that the state does get rebates on for example, pharmacy meds. So I think we did have at one time a PMPM displayed of about 1,500. Some of that is not is cost that is reduced after rebates, but your point is valid that it has decreased during the post-health emergency.
Yeah, I think that's an interesting point. I know that the intensive outpatient clinic that the University of Utah started to kind of address some of the high utilizers in their system, the kind of high cost generators. And it was this population, substance abuse, mental health, unstably housed, trauma, et cetera, et cetera. The first year, their costs are quite high. It's kind of the healthcare for these individuals playing catch up. And then if they followed them, to year 2 and year 3, they saw decreases. That just touches on some of definitely, Adam, what you brought up and some of the other comments that, what are the nature of these costs, and do they stabilize if they get plugged into primary care and get some of their substance use disorder issues under better control? But that first year is sometimes where the system spends a lot on them, takes care of things that hadn't been addressed. So I think it would be really good to look at a timeline of costs, just as Adam is suggesting.
Sounds good. So thank you all for your input and comments. I think we've got a packed agenda, so I'll kick it back to Jennifer. Thanks.
Okay, thank you so much, everyone. We knew this would be, well, we hope this would be an area of interest to you, which is why we wanted to really present it to you early on in our discussions. Certainly can revisit the data as often as needed and evaluate it from different perspectives as well. So thanks for the contributions to that discussion. We are a little over on time. Want to make sure we're able to transition and go through the framework of House Bill 413. So Representative, if you'd like to just transition and move into that section. Thank you. Thank you.
Thank you very much. So as Nate gave a kind of a history of the inception of the TAM and the TAM bill, it was not an easy lift, but in my opinion, it was worthwhile, and it has helped thousands of people over the last 5 years, I suppose it is. I have a question for Brent. Brent, are you going to go through the specific items in the legislation when you talk about your goals and the issues?
I plan to, Representative.
All right, then I will not do that. I'll just give a broader view. When we initially started TAM, by design, we did it as fee for service. And there was a couple of reasons for that. One is we knew there'd be pent up demand in the population. And secondly, we didn't really know what a fair reimbursement or an adequate reimbursement rate for the insurers would be. So we have some history now. And so I think it's appropriate to talk about integrating TAM. And we have our managed care organizations now, or our ACOs. But also we need to remember that this population requires a lot of care and a lot of handling, and they're not like much of the more broader population. And so as we go into this discussion, and I'll let Brent go through the bullet points and the goals and the objectives, but I think one of the main reasons that we're here is to see, should TAM be folded into the ACOs? If so, when and under what criteria? The general concerns I have is we have a shortage of clinicians in this space, as you all know, and I am concerned that as we go into a more managed care setting, do we lose providers and exacerbate that problem? And then secondly, are the ACOs fully cognizant of the needs of this population, and will they be able to address those? I'm not saying they won't, but those are some of my concerns. With that, Brent, I'll let you walk through it.
Great, thank you, Representative. Can everyone hear me? I'm working off my iPhone, but I do have my monitors up, and so it's kind of a strange configuration I have this morning. But we'll get that figured out in the next couple of weeks. I loved the data discussion, and I love the questions that started coming back to us about additional data that we can bring to this group. What I'm going to try and do is give you an idea of the tasks set forth in the bill for this work group that we've now established. And we'll review the goals and objectives set forth in the bill. And then I wanted to talk a little bit with you about the process that you think that we can use to begin working on these issues. As I read the bill, and we did attach a copy of the bill with the agenda and with the data that went out to you, it's a pretty ambitious lift. So as we've talked about it internally, we've had a number of meetings internally about, okay, how do we want to begin working on these issues? One of my concerns is that we could pull together this group and talk about one of these issues for an entire year. And so I think we're going to have to be really strategic and thoughtful and creative about how we address the tasks in front of us. So, to do that, I'm glad that we did the data first, but if there's information that you would like to see, I made some notes during that conversation about, additional cost data, timeline of costs per member per month data, some trend data, the emergency room encounters, maybe diving into arthritis, the types of behavioral health care before clients hit the acute stage. I think those are things that we can look at in subsequent meetings. And I think that's helpful because it'll help keep us grounded in our real goal, which is to focus on the client and make sure that whatever we do winds up improving the system and the quality of care that individuals are receiving. So we'll work with you on that. Looking at the bill directly, starting on line 152, the language there asks this work group to establish specific and measurable metrics regarding compliance of managed care organizations in the state with federal Medicaid managed care requirements, timeliness and accuracy of authorization and claims processing in accordance with Medicaid policy and contract requirements, reimbursement by managed care organizations in the state to providers to maintain adequacy of access to care, reimbursement by managed care organizations in the state to providers to maintain adequacy of care and access to care, the availability of care management services to meet the needs of Medicaid eligible individuals enrolled in the plans of managed care organizations in the state, and the timeliness of resolution for disputes between a managed care organization and the managed care organization's providers and enrollees. During the legislative session, there was a group that met 4 or 5 times with Representative Dunnigan, and my sense is most of these issues came from those discussions. As I looked at this bill and remembered those meetings, it seemed like these were some of the concerns that people were bringing to the table in the sort of formative moments of House Bill 413. And Representative Dunnigan, if you want to speak to that, we can do that. But each one of those is a complex task and a heavy lift. And then I also wanted to talk about, I think, what are really our primary goals that are laid out in the bill, and that starts on line 194. And so this work group was asked to make recommendations regarding how physical and behavioral health services may be integrated for the target adult Medicaid programs. We're looking for ways to improve the delivery of behavioral health services to enrollees, including changes to statute or administrative rule. And then also to identify wraparound service coverage for enrollees who need specific non-clinical services to ensure a path to success. So it's not, this group does not lack in ambition. And I think that we have a tremendous amount of work to do. In addition, we've talked about this. There are other issues that you may want to bring to the table. One issue that's been brought to us is this concept of certified community behavioral health providers. So if you go to a national council meeting, if you're involved in behavioral health in any type of organization nationally, you're hearing about states that are moving in this direction. And I think that's something that we likely need to discuss at a future meeting. So that's the task at hand. We've talked about, do we need subcommittees? How often do we want to meet? And we're going to talk a little bit about that with you in a minute. But I want to open that up. In your mind, is there low-hanging fruit or are there priorities that we need to address first? What would be the most effective way to start tackling these issues that are now in front of us?
And if I could just comment for a minute, one of the items that we had discussed in our preparation for this that I would like to put on the table as Brent's asking this question is, what are some known issues that we need to discuss to kind of clear the board around barriers that may exist in delivering services to this population. So I think one of the things that we talked about is some of you have experience in this model of integrated delivery already, and we'd like to hear what works and what doesn't work in that before we identify what the right path forward is. What is your experience so far, and how do we actually be just honest with some of the challenges, but also the wins as well, so that we can build on those pieces. So
yeah.
Go ahead, Brent.
Well, no, thank you. And this is the part of the meeting that relies on you. We've brought you to the table because it's almost like the Justice League. We've got, I think, the people in this meeting who know more about TAM than anybody else, and so we really want to hear from you. Like Jen said, what are the challenges? What are the opportunities? What could we do differently to improve this program?
Hey, Brent, it's Tim, and I'm on the phone, so I apologize for just interrupting. I think one of the things that we all need to consider and keep in mind is, as we at the county level are managing the legacy Medicaid product, we're also in a lot of our specialty programs like drug courts and mental health court. There's been an increased presence of TAM consumers. And we, at the county level, we've had to really utilize other dollars, non-Medicaid dollars, in some instances, to really help with care coordination. When you have a mental health court judge and they're trying to coordinate care, whether or not the individual is legacy Medicaid or integrated or TAM, really can't really drive how the court is run and how they're navigating getting some of those individuals connected to treatment. And so I think one of the other things we need to really remember is this population is highly criminal justice involved, and it's by the nature of the benefit design. And as we move towards capitating this into the ACO structure, understanding some of the challenges they may face in being able to provide some of that additional care coordination, because again, the courts and some of our specialty programs, really that's kind of invisible to them, and they just really need help in navigating the system. So those are some additional thoughts.
Tim, thank you. And we've had that discussion internally also. Adam, I see your hand.
Sure. So I think there are two things I think we probably need to tackle. The first is payment. And making sure that we have kind of touch-in points on making sure that payments are actually happening as promised. And we still continue to have issues with even the rate increase that happened on July 1st. And I know most of the providers haven't been paid except for Select Health on the new rate, the back pay on the new rate from July 1st. And I think going forward, there's another rate increase that's going to occur on July 1st. And we want to make sure that when these happen, that they're happening when they're supposed to happen. We're not having to fight for, almost now a year to get the rate that we should have gotten to begin with. I think the other part, that's super dense. So sorry, but I just want to, in the interest of time, I think the other thing that we need to talk about is the true complexion of the population and what a positive treatment outcome is and what the duration of that treatment was, and what levels of care, and making sure that we're not creating new barriers to this population, because any barrier that we put in front of these people likely would mean that they don't access care, or they don't get the correct dosage, and then they're continuing their cycle in the criminal justice system, which we're trying to prevent. So I think it's really important that we give, at least from the provider perspective, the managed care organizations, that this population looks a lot different than the commercial. And when we're talking about residential or PHP or IOP, we're talking months, not days. And that's really important to know. Thanks.
Thanks, Adam. I see Johnny Dot, and then Lisa, and then David. So let's try and go in that order.
Thank you. I just want to speak to I think we need to think about there are a couple of different layers of integration that are being discussed, and they're kind of all getting mixed together. But so there is very much integration at the payment level and the plan level, but then also really thinking about at that service provider level, what that integration team looks like, and making sure that the providers that we have in the system are set up to handle the need that's coming in and have experience with that integrated care team model. And then also that the payment model supports the delivery of integrated care at the service provider level. So it's not just about where you're sending your EDI claims, but really making sure that all of the different components that Tim touched on are also folded in to that mix so that we're able to provide that service at the provider level and ensure that those individuals do have the outcomes we want.
Yep, excellent. Lisa?
Yes, I think that was a great summary, and I think what's at the basis and the purpose of this work group more than anything is helping the communication work like a well-oiled machine, and that hasn't been the case in the past. And so I appreciate Representative Dunnigan creating a format and I hate to say this, but teaching us some of the basics of communication, because everybody wants these things to work. Everybody has a lot on their plate. I know that the ACOs have a lot of priorities, but I feel like in building that bridge, it's difficult to handle some of the bigger issues when we haven't solved the way to communicate and become a priority for behavioral health with the ACOs and get the payment. So I feel like it makes it difficult to go ahead when it's 6 months later, and as a small but worthy nonprofit, I haven't gotten paid. So it makes me wonder the increase. I think some other things have definitely improved. We're heading into the new fiscal year with another increase. And so I'm not looking so much at payment or access or things like that. It's like when there are issues, how do we resolve them in an efficient way with the ACOs and communicate in a way that actually can get things done and bring the focus back to the client?
Thank you. David, and then Russ.
Yeah, I guess some thoughts on that. I mean, we talk about integrating TAM, but really TAM has an integrated benefit already currently. What they don't have right now is case management or care management. And so as we look at that, I think that's a piece to focus on, especially I know some of the data Brian presented, this is a different population. So maybe we look at different solutions than kind of what we've done traditionally. And you brought that up a little bit, Brent, with the CCBHGs. There's also PCCMs. There's other models out there. So I just don't want to think that, oh, we need to default to what we already have. We have an integrated benefit now. We need some case care management. Maybe there are other types that's going to fit this special population better than what we're already doing.
Thank you. Russ, and then Nina.
Yeah, thanks, Brent. Well, maybe first, if there's anybody experiencing payment problems with Select Health, I'm going to put my cell phone number in the chat, and you can just contact me directly so that I can get them resolved. Second, I didn't want to derail it from the conversation just on in the discussion of barriers from providers. So I put my hand down earlier, but I wanted to say on what's in the bill. I think there's some clear metrics we can develop there. So one, compliance of managed care organizations with state, federal Medicaid requirements, managed care requirements. The EQRO audits are a great way to look at managed care compliance overall with regulations. And we have to go through those, and we've done that now for the integrated population. And then the timeliness and accuracy of claims processing. We should be able to get to a kind of a metric that's, provider by provider and percentage of claims paid on time. And those are existing measures that we have. And then I think on that reimbursement piece by MCOs, again, hearing some feedback here, I want to get that resolved. So I just think generally we can come up with some metrics here that already exist to put visibility on, are we meeting these metrics?
I agree, Russ. One of my goals in this role is to help us align. We've cobbled together behavioral health budgets for a generation, and every payer thinks they own the provider. And I say that from our office also. I mean, we have data requirements that complicate the life of providers to the point where they don't want to do business with us. And so if we could work better as payers and develop more collaboration, more coordination about data and reporting requirements, I think that we could ease the burden that providers have today. And I think my office is primarily responsible for the mess. And so, we want to work with you to help align the requirements from what used to be the Division of Substance Abuse and Mental Health with the rest of the payer structure. So that's a great comment. Nina, and then Joel.
Yes, I apologize for the noise. I'm at a conference today. Part of the reason I really wanted to be on this group was to have a voice for the disconnect with acute inpatient. And there's a couple of thoughts I have on that. One is we need, as we're moving forward, in order to be able to provide for this population, and we get calls for this vulnerable group all the time for acute care, for medical detox, et cetera. But we have billing issues. Because it's a fee-for-service based program, when we call in to get pre-cert, we're told we don't need to get pre-authorization. This is just kind of an example of where some of the barriers are. And so we proceed because they say anybody who's a Medicaid provider can see someone. So we admit, and then it gets denied because we don't have pre-cert. And it goes back and forth and back and forth and back and forth, and we never get it resolved. And this is an example of somewhere where we need a metrics or a process to then take it to the next level of, well, then who do we talk to when we go back and forth and back and forth? Also, it's very confusing to us billing codes. For example, we're told we can't bill intensive outpatient because you can't do bundled billing as a fee for service, like 15-minute increment, CPT code situation. However, some of the integrated Medicaids are very happily, and all of them are doing inpatient billing on a bundled revenue code. So this is where it gets really confusing of we can't, and yet we have all these populations that between being told we either can't bill and don't get paid because we don't do bundled billing and that type of billing doesn't exist in the system, and then being told we needed a pre-cert, but then being denied because we don't have a pre-cert, is where providers such as us get into the situation of we don't take TAM anymore because it's very hard to justify this to administrators when I can't come up with a solution to it. So this is the kind of situation that is a huge barrier to helping these folks. And there's no reason in the world why, with such few acute inpatient beds and such few intensive outpatient programs for mental health and substance use and detox, we're almost completely out of the picture. So I'm hoping through this work group we can come up with some solutions for that. The other issue is acute care, I think, does a terrible job of working towards any of the social determinants of healthcare. And that's something I'm hoping that we can find a way to, because that's also part of this group's mission, is the wraparound services. And I don't think that acute care is doing as much as we can. So I'm hoping that everyone can put on their thinking caps about ways that we can do a better job at discharge as a handoff of working towards these things. And just because we've never have in the past doesn't mean that we shouldn't. So maybe we can all be thinking about ways acute care can do a better job to help the community providers with lasting results.
Thank you. We have time for maybe one more comment. Jake, we haven't heard from you yet. And then I would encourage the rest of you who want to make a comment to use the chat function. And we're recording this meeting. We'll gather the information in the chat also. But we want to do some planning for our next meeting. So Jake, last comment here in this section.
Well, the pressure's on. So I think as an organization, you've heard from several of our members about some of the stucks that we're having around payment, around access, utilization reviews. A lot of the administrative stuff is a big problem that we faced over the last 3 to 5 years. And I think before going forward, we have to solve those issues so that we can have confidence as a body that these issues are being resolved and that they're done and that we're moving forward. Because I think that there's a little bit of a trust issue right now with the ACOs and the body of organization, the providers. I don't think it's an intentional thing. I think it's just a cause and effect of what we've been dealing with. And so the majority of our meetings are trying to collaborate and provide solutions to membership about how we can solve these issues. And I think this is one of the biggest benefits that we could have for this body, solving these issues. And I think in the solutions of these issues lies the remedies for what it is that we're going to need to do to go forward. So I would love to just get a status update from the ACOs about where they are and how they, where they are on payment, where we are on, to Lisa and Adam's point and others, about getting payment that's retroactive and then getting current. We have another pay, as Adam said, a rate increase in July. So I think just if it's possible, and maybe it has to happen in the next meeting, but I think we need to spend a very significant part of the meeting on figuring that out. And then, like I mentioned, I think in those solutions, the remedies go forward.
Okay. And we still have a few hands up. Joel, I said Jake had the last word, but you do. And then, I appreciate the thought. This is exactly what we wanted to generate. So for those of you who, didn't get an opportunity, use the chat. Let's talk offline, and we'll address these issues going forward. But Joel?
Right on. Thank you, Brent. Can you guys hear me?
Yes.
Okay. Just wanted to echo a couple things and really kind of focus back in on the purpose of this committee as we kind of outlined it over the session. What we're primarily and fundamentally dealing with here is reimbursement mechanism. At its core, the clinical alignment, the clinical and medical integration, all those things kind of come also. And I would say secondarily to ironing out who's paying for what and how we align the different pots of Medicaid. Not in a way to put finances first or anything like that, but just to identify, correctly where the dollar flows. And especially with the change in your shop, Brent, your shop's probably been the kind of the most stable entity in this space for quite some time. And now that it's going to be going through changes while at the same time we're addressing TAM, while at the same time we're addressing, multiple different potentials. And I do want to touch on the addition of B3 services and some of the wraparound services that were briefly touched on, but are sorely needed. The compression, and just so a couple agenda items, and honestly, the ACOs have been great to work with throughout the process of this committee. But one thing we've noticed, and we had a provider meeting yesterday, but it's as far as the retro increase, which was committed to during the session. How do we identify how that's coming across, whether it's come across, what it looks like? Is it tied to a payment? Is it tied to a claim? Is it, or is it just an assumed, missing amount that is being made whole? And I'm trying to go as quick as I can. And feel free to.
Well, no.
Go ahead.
Okay. No, thank you. And we agree with you. And we're not going to. I don't want to dive too far into these issues, but I wanted to get the group thinking. Jen's going to close. We wanted to have a discussion with you about meeting frequency and whether this meeting should be virtual or in person. And then also, I did say we could talk offline. Let's not talk offline. This is an open and public meeting, so we'll do our business here in this forum, and so that we all have access to the same information, that the public has access to that information. So anyway, Jen, do you want to lead this meeting and close us out?
Yes, thank you. And again, thanks to everyone. It was a very quick hour and a half, I believe, and lots of ground covered, but so much more work to do. We did, first of all, set a placeholder based on some of our internal staff availability for a recurring meeting on Fridays And our next meeting is established on June 10th from 2 to 3. We know that this is our kickoff meeting, and finding a time where we can all meet can be a challenge. This was a time we have identified, and if possible, we would love to try to secure that date and put it out there. There is an opportunity also to, as Brent mentioned, I do believe we need to come back to the topics that were identified today. We are planning, we've recorded the meeting. We also are taking minutes. This meeting, because of the nature of it, these will be publicly available, and we will share where that site will be once it's established, so that all of these materials can be posted on time. They will also be distributed to you as work group members, so you will have those. For our next meeting, we'd like to come back to the topics that were brought up here. So we need to synthesize what was discussed and kind of put it into groups. We appreciate all of your comments and your contributions to this. From this, we will organize work with Representative Dunnigan on organizing a next step for an agenda. We recognize it's a broad array of items that were brought up, and so we will need to chunk our work. To Brent's point, we do also want to have open discussion around smaller working groups and the frequency of our meetings. So with that, Representative Dunnigan, is there anything you'd like to close with in our last minutes here?
I just want to thank everybody, and particularly Jan and Brent, all of you in the health department. You guys have been fantastic to work with. I've worked with some of you more than others, and the providers, ACOs, thank you for all being willing and interested to dive into this and see what we can accomplish.
Okay, thank you. We will be distributing the invite for Friday, June 10th, following this meeting. So you will have that on your calendars. It is a recurring meeting every 2 weeks. We can discuss that at our next meeting as well. So sorry we ran out of time at the end here, but we'll work on our recurring meetings after this. Thank you, everyone.
Thanks.
Thank you.
Thanks, everybody.